We've got Tasha McNerney with us, and she is going to talk to us today about calculating continuous rate infusions. Tasha McNerney has worked as an anaesthesia technician outside of Philadelphia for 12 years. Tasha has been a featured speaker on various anaesthesia and pain management topics at conferences across North America. She has authored numerous articles and textbooks, chapters and journals. Tasha has recently obtained her certified veterinary pain practitioner. Thank you.
Yes, hello. Oh, hi guys. Hello. All right, there's so many people here compared to at 9 a.m. It's a big difference, right? It took a while to get caffeinated and to wake up. Hello. How's everyone doing today? Y'all showed up for the drugs talk. Very interesting, right? We don't care about the anesthesia machine. We want to know about the drugs, right? That's what I always care about. I mean, not personally. For my patients. We could talk about the other afterwards. But we're going to talk about constant rate infusions. How many people in here are using constant rate infusions currently? Almost half of the audience. So why are you here? You already know what you're doing, right? This is easy math. Don't stress yourself out about this. It's easy. No problems calculating this stuff. So we're just going to go through a couple of different ways that you can calculate constant rate infusions, when you might want to use a constant rate infusion, etc. Certainly not only for analgesics, sedatives can be used as constant rate infusion. You can set your antibiotics up for a constant rate infusion if you want a long, slow administration to prevent nausea and vomiting. So there's all kinds of drugs that we may want to put to infusion over time. We're just going to go through them in a nice 20-minute session to get you guys on to your next session, okay? Yep. If at any time you have questions, just ask me at the end of the session. I'm not at the end of the session. If you have a question, if I'm saying something incorrectly, you don't understand what I'm saying, or you're unfamiliar with the term, just stop me during and ask me. Very informal, okay? So there's many benefits of a constant rate infusions. We want a steady delivery, and that prevents the highs and the lows of intermittent bolus administration. So certainly, how many people here are doing anesthesia pain management? Yay! No, come on, you guys are doing anesthesia pain management. You're doing it all the time. How many people love anesthesia pain management? That's what I really want to know. Yay! Any anesthesia nerds out there? What, a couple? Anybody on the group anesthesia nerds? Like one person raised their hand in the back? Oh, yay! There's a Facebook group called the Veterinary Anesthesia Nerds. My friend Steven here in the picture wearing our nice logo that we have started. It's a Facebook group that we started to discuss anesthesia nerd stuff and geek out about veterinary anesthesia stuff. So if you're ever on Facebook and you want to geek out over anesthesia stuff, clearly you have nothing to do on a Saturday night, and you're like, I want to read about ketamine. This is the place for you. So benefits of constant rate infusions are many. There's less overall nursing time needed. Once you set your constant rate infusion and you figure out the right dose for your patient, there's less overall nursing time because you don't have someone every 4 hours calculating out the dose, using the extra drugs, logging those drugs, etc., and then delivering it to the patient, okay? You're putting it on, it's not a set it and forget it, I don't want you to think that, but it certainly does help with your nursing time, so then you're only going in and maybe pain scoring the patient instead of actually calculating out drugs and administering drugs every 4 to 6 hours. CRIs can include multiple agents. You can get multimodal analgesia. So I know in our practice, if we have a big fracture repair or a disc disease dog that we're doing surgery on, we might want to run something such as a morphine and ketamine CRI, again, because we want multimodal pain management on board for those patients. There are some concerns, however, regarding CRIs. You do want to make sure that while your patient is on a CRI, especially if they are on a multimodal CRI, so this was a external fixator stabilization for a fracture, a radial ulnar fracture after this pup was hit by a car, and he was having a really hard time post-operatively with the intermittent morphine boluses, so I put him on a morphine, lidocaine, ketamine CRI. So MLK CRI, super cheap, super easy to calculate out. There are many different calculators out there to help you because I work at 2 different practices. One is a primary practice and one is a specialty and referral practice. At the primary practice, they don't have syringe pumps, so all of our CRIs are done via the fluid bag and the fluid pump, okay? Now, if you have syringe pumps, those do provide more accurate dosing. But to calculate a CRI, it's pretty simple. You just want the amount of agent added to the bag, and to get that, you want to look at your rate, so whatever you and your doctor have discussed, as your mgs per kg per hour, or micrograms per kg per hour if you're dealing with agents such as fentanyl. Okay, maybe want to do your calculations in micrograms. If you're using dexmedetomidine, micrograms would be acceptable. You want to divide that by your fluid rates, whatever your doctor has decided as the fluid rate, mils per kg per hour. Usually we're keeping these fluid rates low because then if we need to supplement their volume, if they get hypotensive under anesthesia, we wouldn't want to bump up their fluid rate of the CRI because then they're going to get really, really loaded on drugs. Does that make sense? So we usually keep these fluid rates pretty low so that way we can play with volume in another capacity. And then you want to look at your diluent. So if you have a 500 ml bag, if you have a liter bag, etc. Now, if you want to talk about CRIs that you can make up, a morphine, lidocaine, ketamine CRI is one of, again, the most cost-effective CRIs that you can use with the most multimodal pain control available. So multiple pain pathways are covered in this infusion. You have an NMDA receptor antagonist. You have the lidocaine, which is going to actually be a free antiarrhythmic. So you can, that's beneficial if you have like a splenectomy patient or if you have a GDV patient. We find this CRI very helpful. It's extremely, extremely MAC sparing when you use these multimodal CRIs. So sometimes if I have a dog on a MLK CRI, I can get my sevoflurane down to sometimes 1%. If they're really responding to my CRI. I had a Pomeranian that needed 14 dentistry extractions. Had him on an MLK CRI because he also had liver and kidney issues. So I didn't want my inhalant high. I want to keep my inhalant low so it doesn't influence him pressure-wise. I want to vasodilate him. So he was on a MLK CRI, and I was able to keep his SIVO at 0.5%. So for him, again, it's patient-specific. Every patient's different, right? But for that, some patients, extremely MAC sparing. So if you're worried about vasodilating them with your inhalant or you want to reduce your inhalant, keep your inhalant low, a CRI is a nice multimodal way to go for these patients. So if we were just doing if I was going to do an MLK CRI, okay, and I had a liter bag, if I want to calculate out the amount of morphine to this bag, this is how I would do it. Now, this mgs per kg per hour can be changed. This is just the most common dosing. If you wanted to use the low end, most common dosing of morphine at 0.1 mgs per kg per hour. If we times that by our milliliters, and then we're running it at 2 mils per kg per hour, again, if you're running a surgical rate of 5 to 10 mils per kg per hour, you can do it that way. But again, then you're going to have to very, very be careful when you're bumping up and down your fluids. Because if you bump up and down your CRI, you're giving more and less drug. Does that make sense? Okay, so we usually use a 2 mils per kg per hour as a standard. And then if we need to add volume because they're hypotensive, we add a crystalloid at a separate volume on a separate pump. So they're two separate pumps. So for this patient, if I was doing 0.1 mg per kg per hour, again, I'm assuming a 10 kg patient, then I would add 50 mgs of morphine. I know that in the notes there are exact calculations, so don't feel like you have to write down all of these calculations here. They're very simple calculations that I put in your proceedings notes to calculate these things. I think I went through fentanyl CRIs and morphine CRIs, but it's very easy math. You guys can do this, no problem. So if I wanted to add lidocaine to this bag, if my lidocaine is 2 mgs per kg per hour, which is a standard dose of lidocaine that we use. That's pretty across the board. Again, assuming the same 1,000 ml bag, when I do at the math, I'm going to add 1,000 mgs. I'm sorry, that should say lidocaine. I apologize. We wouldn't want to add 1,000 mgs of morphine. That patient would be way high. We want to add 1,000 mgs of lidocaine. So just be aware that when you're adding these volumes, we noticed I had 3 mLs of morphine in the previous one. Now I'm adding 50 mLs of lidocaine, and I'm going to end up adding a ml of ketamine. This is for my MLK CRI. So just be aware that all of this volume that I'm going to be adding to the bag, I have to take out an equal part of saline. Okay? So for instance, if I have 5 mLs of morphine plus 50 mLs of lidocaine plus 1 ml of ketamine, that's 56 mLs total of drug I'm adding to the 1,000. So in order to keep my math correct, 1,000, right? I don't want to be 1,056. In order to keep my math correct, you need to take away 56 mLs because I'm going to be putting in 56 mLs to make the 1,000. that make sense? So just make sure that whatever volume you're going to be adding in, take it away of your saline first. And also make sure to properly label the constant rate infusions with the mgs of each drug added, because some animals could be very sensitive. For instance, the effects of lidocaine in cats. If you had a lidocaine CRI, you want to make sure you label that bag so someone inadvertently doesn't pick that bag up and start a bag of lidocaine CRI inadvertently on a feline patient. So if you have a CRI via IV fluid pump, if we had a 30 kg patient and we run the CRI at 2 mils per kg per hour, again, pretty simple math, that's going to be 60 mLs an hour. Now we run additional IV fluids at 3 to 5 mils per kg per hour on our surgical patients. So if they become hypotensive, I can go to my regular Plasmolite, Normar, lactated ringers and go up or down via there instead of going up or down my CRI. However, if I feel my patient is still painful under anesthesia, then I can go up or down on my CRI, right? If you feel like your patient's too deep with that, titrate down on your CRI. If you feel like, man, it's just not hitting the mark and I still feel like they're experiencing some pain, go up on your CRI. That's the beauty of the CRI. You can titrate it up or down according to what your patient specifically needs. Again, if you feel like you need a fluid bolus, do not bolus the CRI, bolus your IV fluids. In the postoperative period, I do use a ton of CRIs in the intraoperative period, but I really, really like CRIs in the postoperative period as well. I think as nurses, they make our jobs very easy in the postoperative period because they keep our patients so comfortable and pain-free. And it's mentioned before, I recently obtained my CVPP, so I am a certified veterinary pain practitioner. If you guys are interested in getting further certification in pain management, I could talk to you guys about that afterwards. But pain management is really my area where I feel very strongly about and think that we, as nurses, that's why we got into this, right? We want to make our patients feel better. We want to make sure that they wake up from surgery not in pain, not screaming and howling. So CRIs work very well for that. And if you guys are coming to my dexmedetomidine or alpha-2 lecture tomorrow, we're going to talk about specifically dexmedetomidine CRIs and how you can use those in the intra and postoperative period to really make your patients comfortable. We know that patients in pain afterwards experience a lot of not only physical effects, but psychological effects as well. When our patients are painful in the postoperative period, we see an increase in heart rate. They have an increased incidence of arrhythmia. They have hypertension. They have ventilation abnormalities, right? Patients who are really in pain. You've seen these patients wake up from surgery, right? Sometimes they're howling. Not a fun thing to watch. So we want to make sure we're really treating pain in the postoperative period, and a CRI can really help you with that. A lot of times when I go into practices, I do a lot of teaching in practices, in clinics. I will let you guys know that I do sometimes work for Zoetis in the United States because of my experience with dexmedetomidine and medetomidine. And I go in and I help clinics learn how to use this drug and how to make it work for their practice. And oftentimes, a lot of nurses come to me and they say, well, I don't know if I want to give him more drug because he may be dysphoric, or my doctor thinks he's just dysphoric, so I don't want to add any more opioid, or I don't want to give anything else for pain because he's already dysphoric. So I think that as nurses we should always, always err on the side of caution and always treat for pain first. Assume your patient is painful if they've had a painful surgery done, right? Makes sense? Anyone here ever had a painful surgery done? Yes? Anyone here ever had a painful surgery done and felt like their analgesic was inadequate afterwards? Yeah, I've been there. I had abdominal surgery, and I was very annoying to the human nurses. So I was like, I will give you a study on dexdomitor, and they were like, be quiet. So in the postoperative period, we want to make sure that we look at, are our patients dysphoric? Are they experiencing emergence delirium? Have we provided them with appropriate analgesics? And this patient here, I probably can't get the audio on it because I didn't set it up this way, but this guy here was recovering from, I think it was a cryptorchid surgery. That's not working. But if you could just look at this guy, he was in his crate, waking up after surgery, and this is the sound he's constantly making. You've heard that dog, right? He's been in your practice. So what do you guys think? At first we thought, oh, maybe he's a little stoned on his opioids. maybe. But the thing was that no matter who passed his cage, he would respond to them. Okay? Usually if patients are truly dysphoric on opioids, if I walk by his cage, they're not responding to me. Okay? He wouldn't sit down. That's another key. Okay? When they're constantly up and they're down and they're up and they're down and they can't sit down and get comfortable, we want to provide additional pain medicines. Okay? So reevaluate your pain control. 5 minutes. So we want to always provide analgesics. Again, in the postoperative period, if you feel like you've already given enough opioid or that patient's at its max dose of opioid, consider maybe a CRI of metatominine or dexmedetomidine. The nice thing about this drug is it can be titrated with just a few micrograms, and it can be on a CRI. It's very easy math to do as well. And again, I could talk to you guys about dexmedetomidine tomorrow or alpha-2s in general, or after this lecture. But the nice thing about it is not only is it a sedative, but it's also an analgesic. It's labeled as an analgesic, and it functions as an analgesic, and it's a nice complement to your opioids. And it's reversible with antecedent if needed. Now, how many people have a syringe pump in their practice? Anyone have a syringe pump? Okay, quite a few people. If you have a syringe pump, your life is just made even easier, correct? At my one practice, again, we don't have a syringe pump, and then when I go to the specialty practice, we do have a syringe pump, and I almost feel like there's less actual brain work, less math that I have to do, because you kind of punch it in to the machine, and it does the work for you. And we always check our math against the machine because, right, we know machines sometimes will lie to you, right? If you guys are using a pulse oximeter in your practice, you know that machines will lie to you, right? How many people have seen a pulse ox of 84 on an animal that's on 100% oxygen and perfectly pink? We know these machines will lie to us. So always check your math. But syringe pumps are very nice. I personally am a fan of the Baxter brand syringe pumps. You can set your mgs per kg. You can set your syringe pump to mgs per kg per hour mode. You enter the patient's weight in kgs. You put in your calculated dose, and it will figure out the math for you. So there's no how many mils per kg per hour do I have to do. It's just that certain volume that you've drawn up into the syringe that it will titrate over a certain amount of time. Okay, so syringe pump is a very easy way to go. I feel like I don't need to go too in-depth into a syringe pump, but I can if you guys want to. And there is more information in your proceedings and in your notes about calculating specific CRIs and looking at syringe pump. So in summary, they can be done via syringe pump or even a regular fluid pump in a bag of IV fluids, large bag, little bag if you have a little patient, okay? You want to calculate each drug to be added individually, and you want to increase or decrease that CRI based on the patient's comfort. So again, if they're on an MLK CRI, which is a multimodal CRI, and you feel like their pain control is adequate and their owner's going to come pick them up in 24 hours, then let's start weaning them down off of that CRI and they can get on oral analgesics to go home. Okay? But if you feel like they're still painful, well, then maybe we need to double the rate of this CRI and give them a little more pain control. Or maybe we need to add another drug class like an NSAID or an alpha-2 antagonist to better provide some pain control. Okay? If you guys have any questions, certainly I can answer them in after period, and I'm around today and tomorrow. If you have any questions on pain management or anything drug-related, I can answer that. If you have any vaccine questions, I absolutely have no idea. Thank you guys for coming.
Thank you. Thank you, Tasha. It was great.